going to be getting started with the next lecture since we were just running a tad bit behind, and I know we have some workshops after all of this. So anyways, first off, just like to thank everybody who showed up this morning. You know, I realize that this is the last day of the conference. So, you know, some of us have planes that we have to catch later today. Some of us have workshops that we're looking forward to, whether it be the hands-on stuff or the cadaver lab. And then some of us may have gone out for Cinco de Mayo last night and are kind of wishing for a Meyer cocktail with a 500cc bolus of normal saline. But I'm going to try to keep this as interesting as possible. My name is Dr. David Nebbeling, and if that name sounds familiar to you, that is probably because there is another Dr. Nebbeling in the room. He's a tall, bald guy in his mid-60s sitting right over there. Raise your hand. Yeah. So a lot of people think I look like the mailman's kid, but believe it or not, that is my dad. And we work together at Advanced Osteopathic Health in Lansing, Michigan. So our primary focus is regenerative medicine, you know, seeing a lot of pain patients and MSK. So, you know, using a lot of the things that you're already familiar with that we've talked at length about, doing a lot of PRP, prolotherapy, manual manipulation, those sort of things, ozone. But just over the past, I'd say 2 years, we've added a new modality to our practice to kind of work synergistically or, you know, supplemental to those other techniques, you know, another tool in our toolbox, and that has been shockwave therapy. So, you know, I was at this conference last year and I was talking with some of the other docs, and it sounded like there's a lot of people that weren't really familiar with this, or maybe if they were, it was just in passing. You know, maybe a patient brought it up, but otherwise it sounded like we really hadn't had a lecture on this. So that's kind of how I volunteered myself for this lecture this year. It's called shockwave therapy. Other people call it extracorporeal shockwave therapy. That's kind of a mouthful, so we'll probably abbreviate it as ESWT or EPAT therapy in the lecture. But just a quick show of hands, who here is familiar with shockwave or has used it? Okay, so we got a couple people. All right, good. So, you know, as we go along with this lecture, you don't need to hold your questions for the end. I want to make this as interactive as possible. And I realize there's a lot of really smart people in this room with just a whole host of experience. I know we even have some old timers here that have been practicing for 4 or 5 decades, you know, back when they used glass syringes and reusable needles. So they've seen the evolution of this whole regenerative medicine movement. So, you know, I appreciate any questions, comments, or concerns along the way. But let's get started. So the outline of today's lecture, we're going to go over a little bit of the history of shockwave therapy, how we think that this actually works in the human body. We're going to go over just some of the devices that can be used to do shockwave therapy. And then, of course, you know, therapeutic uses. What can we actually use this therapy for? As with any of these presentations, we should be backing up whatever it is we're talking about with at least some research. And I think probably the most interesting part of the lecture, at least for me, with my experience in shockwave, has been the synergistic use of shockwave therapy with other regenerative medicine techniques. And then lastly, I'll just give you a little bit of my own experience just from some case studies. So the history of shockwave therapy. You know, this is one of those topics where if you start reading on it, researching it, looking it up, it can get really complicated really quick, especially if you're like me, who is not a physicist. But this is something, shockwaves, we've known that they've existed for a long time, at least theoretically, you know, going all the way back into the 1700s. But it wasn't until 1887 that this cat by the name of Ernest Mach was actually able to photograph a shockwave from a speeding bullet. And this is the same Mach who, you know, Mach 1, Mach 2, Mach 3 is named for. And he was somehow able to film this or, you know, get a photograph of this, which still blows my mind, you know, the technology available in 1887. And somehow he was able to get a picture of a shockwave from a speeding bullet at just the right time. So that'll be the picture that you see in the bottom of the screen there. But it wasn't until later on that we figured out that it had actual, you know, physiologic effects in the human body. So as with many areas of medicine, you know, when there comes a great war, that brings about a lot of new medical knowledge and medical advances. Obviously, World War II did that profoundly. So when it comes to shockwave therapy, though, it was these depth charges that were being laid, and these sailors that had these massive internal wounds without any external marks on their body. And that led us to figure out that there are these shock waves that can travel through the human body and hit an internal target and cause some sort of effect. So fast forward a little bit more, and naturally that led to the idea of, hey, if we can pass a shock wave through the body and hit a target, is there some way we could do that safely to, say, break up kidney stones? So some of the first lithotripsy using this method. And then fast forward a little more, and we now have machines that can be used for musculoskeletal purposes. So some of the first FDA approved uses for shockwave being in lateral epicondylitis and also plantar fasciitis in the early 2000s. So mechanism of action, how do we think that this actually works, especially in the human body where this can cause extreme damage like we saw in World War II, to basically how can we use this for regeneration? Again, this is a topic that if you start looking at, there is just a ton of research on, and there's some really smart people who are laying out these specific pathways, but it seems to be that they like to divide it into a few different steps or categories. The first step is going to be that physical or mechanical force. So that shock wave is a pressure wave moving faster than the speed of sound. It's passing through the body, and that's the mechanical or the physical force. And then there are later downstream effects that, it may be semantics, but they call it physiochemical, chemical, biologic effects. I just kind of group it all together. But that's how you'll see it kind of divided in the research. So that first initial step, like we talked about, is that pressure wave moving faster than the speed of sound. It propagates through the skin and through the tissues. And while it does this, it causes something called cavitation bubbles. And please, dear God, do not make me explain what a cavitation bubble is, because it is way above my pay grade. But the important thing to know is that these cavitation bubbles in the tissue actually implode on their target, and they induce a microtrauma. And then that microtrauma goes on to lead to these further downstream effects, these physiochemical, biologic effects that we're probably more concerned with. So there's, like I said, a lot of different pathways out there, but I highlighted just a few of them that I thought would be most interesting to us here. So one thing that we know is that it does elicit and enhance ATP release by cells. Now, ATP is involved in a lot of different pathways, but the ones that we're concerned with is the enhancement of basically cell proliferation. And what cells are we talking about? I'll give you a quick quote from some research articles here, and that is that radial shock waves significantly promote the proliferation and self-renewal of mesenchymal stem cells. Other pathways that we're interested in, nitric oxide. So this is one that I'm sure a lot of us are familiar with, whether we're using nitric oxide in our practices for patients that are deficient. And somebody correct me if I'm wrong on this, but I think by the time we hit 50, our levels are decreased by up to 50%. And nitric oxide is one of those chemicals that is just so integral to the health and regulation of our blood vessels, controlling the vasodilation and the delivery of oxygen and nutrients to different areas. And that becomes especially important when we're talking about joints, right? Joints don't heal the same way as other parts of the body because of those limiting factors, right? How much blood flow do they have? What cell lines do they have? Also, nitric oxide, it's one of the few things that can actually heal the endothelium, the inner lining of the blood vessels. So my understanding is that back in the day when you went to med school, endothelium was treated like just this inner lining of a blood vessel, just a tarp with no real functioning to it. But now we know it has just a whole ton of effects. The other important thing to note is that nitric oxide also has anti-inflammatory properties in the human body. The other things that we care about is, the sort of stuff that we would care about with any of our regenerative medicine techniques, whether we're talking about prolotherapy or PRP, and that's going to be, talking about the exosomes, the microRNA, the chemokines, the cytokines, the growth factors, and all of these are induced with shockwave therapy as well. And then what is the downstream result that we're always hoping to get? Along the way, one of them is we're hoping to activate or enhance some sort of cell that's going to lay down more collagen, whatever type of collagen it is that we're talking about. So collagen being the primary structural element of any connective tissue, we want to make sure that we're activating and enhancing those fibroblasts and chondrocytes. So this is a pretty good slide that I stole from, or didn't steal, but reference from another research article. And I thought it kind of did a good job of just going over some of the basic pathways and kind of their end result. So when we're talking about nitric oxide, TNF alpha, COX pathways, that's where we can actually have anti-inflammatory properties with shockwave therapy. And this is probably one of the reasons why shockwave therapy, at least in my experience, as well as some of the research I've seen, can be used in inflammatory arthritises or autoimmune type arthritises without inducing a flare. Obviously, when we're talking about VEGF and these type of pathways, we're looking at neovascularization, so increasing blood flow to these areas. Also cell proliferation, increasing cell membrane and tissue permeability. And the last one is one that I don't really reference a lot here, but it's pretty interesting stuff as far as the ability for shockwaves to actually have an effect on nerve regeneration, at least in the periphery. So I think this would be the topic of probably another lecture and probably one to be further investigated, but just interesting stuff. And here I have another table that I borrowed from another research article. This is probably the most important slide of the entire presentation. It goes through a number of different pathways. So, we'll probably spend the next 30 to 40 minutes just going through this one line by line. I'm sorry, I have a dry sense of humor. I'm obviously joking. I'm not gonna do that. My whole point is just to say that, there's a lot of research out there, a lot of really smart people that are trying to elucidate all these different pathways, as with any of our regenerative medicine techniques. But as most of us know, the human body is so complex, we'll never lay out all the pathways, because then those pathways play into another pathway and it just gets so complicated. But we do have some really heavy duty science that goes along with this stuff. So why should we care, right? So the end result that we're looking for, hopefully, is going to be pain relief, right? Tissue regeneration. And then one thing that is, I guess, slightly unique to shockwave therapy is its ability to destroy calcifications in tissues. So I know we do have other techniques and other modalities to address this, but it's just, I guess, another key point with shockwave therapy to be cognizant of. As far as one of the tools that we can have in our toolbox to address these calcifications and scar tissues. So how do we actually deliver a shockwave? Kind of went over what a shockwave is and the effects it can have in the human body, but how do you actually use this therapy for patients? When you start looking at the devices that are used to deliver shockwave therapy, again, this could be the topic of a whole other lecture, and it gets a little complicated and there's a lot of controversy, but you're basically going to fall into two categories. You either have a focused shockwave device or you have a radial shockwave device. Unfortunately, the names of those devices go right along with what you would think they would do. So if we look at the screen here, on one side, the left-hand side of the screen, we have a focus device. So that gray bar is the source of the shockwave, and that green dot is going to be our target tissue. And as you can see, the shockwaves are narrowing down. They're focusing in on that target. Now with radial shockwave, it's the opposite as far as they are radiating outwards, but still reaching the target. So there is some controversy regarding which one is superior to the other. If you go online and start asking Dr. Google, there's a lot of people making YouTube videos about this, but when you actually start looking at the research, there's pretty good research showing that both are effective. So personally, in my practice, we use a radial shockwave device, and we've gotten good effects with this. So this is kind of what the machine looks like. It has, its main unit doesn't take up a whole lot of space, and then we have our transducer, or our probe, as you can see below that. And that is where the controls are, as well as where the shock waves are delivered through. So a lot of times patients will say, hey, you know, I've had this done before at my chiropractor, because in their mind, it almost seems like a percussion device or something like that. But it's always good to note that it's not that at all. It's actually delivering a shock wave through the tissues. Just full disclaimer, you know, I'm showing you the device we have, which is Storz Medical. We actually have a D-Actor 50 in our office, but in no way, shape, or form did Storz Medical, who's one of our vendors, pay me or reimburse me to be here talking about Shockwave or even mentioning their devices. So if you see their rep Chuck out there, make sure to let him know that he forgot to do that. I do take check and cash, preferably. So what can we actually use shockwave therapy for? There's a whole bunch of things you can use shockwave for. There's a lot of good research articles out there. There's a lot of good protocols. And generally, if you're purchasing a shockwave device, they'll give you just a whole list of different protocols for different treatment or for different conditions that you can treat. But I just thought I would go over a couple of them that I found interesting and that had some pretty good research behind them. And those are calcific tendonitis, plantar fasciitis, looking at our lateral epicondylitis, and ligamentous injuries, osteoarthritis, a lot of the bread and butter that we're seeing in our practices now. Calcific tendonitis. So this is that condition, you know, let's just say 40-year-old female, you know, she wakes up one day and she has this bad shoulder pain. She has limited range of motion with flexion and abduction. Doesn't really seem to have an inciting incident, you know, can't really think of anything that she did. So you kind of have a hard time figuring out, you know, is this a rotator cuff tear? You know, maybe she's already been to the emergency department or to her local urgent care because she woke up with this sudden pain and limited range of motion. And maybe she's already had x-rays. And on the x-ray, one of the classic findings is going to be, you're going to see a calcification in the tendon. Most of the time it's going to be in the supraspinatus, and most of the time it's going to be without an inciting tear. Obviously, it's somewhat an acute presentation in a lot of patients. So it kind of helps you separate it from, say, a frozen shoulder where something's been going on for a while and they haven't been using it. And then that leads to that adhesive capsulitis. But obviously, this is one of those conditions where if you don't get the pain under control and you don't get the range of motion back, I mean, they're going to end up with a frozen shoulder. So evidence shown that shockwave therapy can decrease that pain. It can increase the functioning and the range of motion in that shoulder, which is what we want. But more interestingly, I think, is that actually studies showing that you can get partial or complete resolution of those calcifications on radiograph. And that's what we see here, obviously, in the slide, if you haven't figured that out yet. So a little calcification there of the humeral head. Plantar fasciitis. This is obviously one of the first FDA approved uses of shockwave therapy, and one that I'm sure we see a lot in our practices. Natural history of this, as many of us know, is that, you know, a lot of people, it'll get better on its own, honestly. But if you're one of those unlucky people where it doesn't resolve with conservative management, you know, some good orthotics and some stretching, then, you know, this can go on for years and years and just be absolutely miserable. So we have literature reviews comparing shockwave actually to other standard treatments of plantar fasciitis. And it showed us three main things. And that was that patients responded better to shockwave therapy. Patients had less complications, since this is a non-invasive treatment, right? We're not breaking the skin with a needle or a scalpel. We're not inducing steroids. And then there's actually a clear difference in efficacy between shockwave and those conservative treatments. I don't think I referenced this next point, but sometimes when these patients come in, you know, they won't say they're there for plantar fasciitis. They'll say they're there for a heel spur, right? You know, they went to their podiatrist and they did an x-ray because they can cover it with insurance. And they say, oh, yeah, this big heel spur here. But as we know, you know, that heel spur is secondary to the ongoing enthesitis that's been happening. You know, bone responds to stress by growing more bone, and that's where you get that heel spur. So there's research out there showing in some of these studies that actually these heel spurs decrease in size after shockwave therapy. So again, you know, breaking down these calcifications. Then lateral epicondylitis, tennis elbow, another one of these conditions where sometimes it goes away on its own with behavioral modification, that sort of thing. But if it goes on longer than that, it can be a real bear to deal with. So, you know, dropping things, not having that full grip strength, not being able to carry a pail of water, that sort of thing. And it's been shown to be effective in decreasing the pain, as well as increasing the functioning as measured by grip strength when it comes to lateral epicondylitis. And studies are also showing that this is more effective than a steroid injection. So I realize that most of us in this room are probably only using steroids in the most rarest of cases, you know, being very judicious about it. But it's always a good point to make to patients that, you know, the treatments that we do in regenerative medicine, they aren't just, you know, alternative treatments to what their primary care or orthopod is offering. A lot of these treatments that we're offering are actually, you know, we have studies showing that they're superior to the steroids and all the other stuff that they're offered, that insurance is willing to pay for. So I think in my mind, that automatically begs the question, you know, then why are the steroids and all that other stuff standard of care as opposed to some of the other stuff we do? But that's, again, topic of another lecture, I'm sure. And then osteoarthritis. And this is one that I think is interesting to me, because with osteoarthritis, at least in my experience, this can be one of the more difficult things to treat. You know, when we're trying to address that articular cartilage, that hyaline cartilage, we have, I guess, in a way, less to work with in terms of the vascularity and the cell lines available. You know, this is something that didn't happen overnight, and it's not going to heal overnight. So the more tools we have available in our toolbox in order to address this condition, the better. And obviously, as we get more advanced, right, going from mild to moderate to severe osteoarthritis, just the harder it gets to treat this condition. Obviously, stabilizing ligaments and all that other stuff is going to be very important. But when we're looking at just strictly the articular cartilage, there's been systematic reviews of shockwave therapy used as solo treatment for osteoarthritis, as well as meta-analysis. And it showed that patients had significant improvement in their pain at both 4 and then even more so 12-week follow-up from shockwave therapy. So you know, 4 weeks, I think, is probably a little early to kind of gauge a response, in my opinion. But how we think this is working, some of the ideas out there are that it actually has an effect on subchondral bone. So it's preventing that sclerosis, but also having a protective effect on that cartilage. Usually once a week. So you can push it out to 2 weeks, depending on where the patient's coming from. So in our practice, we have patients driving from all sorts of different states. We even have a small group of Canadian patients that drive out to see us. So sometimes every week isn't possible. So I've pushed this out to every 2 weeks, and that's been just fine. And then ligamentous laxity and tears, a bunch of studies on this. And one that we see all the time in our offices, obviously. And I just reference one study looking at that chronic ankle instability. So I'm sure most of us in this room have rolled our ankle, right? We've had that inversion injury, you tear your ATFL and maybe some other ligaments. Gets better, but obviously the body never forgets an injury, and that ankle usually is never quite the same. In some patients, they have this chronic instability and just ongoing problems ever since that injury in high school or in college when they're playing volleyball or basketball or stepped off a stair the wrong way. But a study showing that it improves pain, it improves the stability, and then obviously function and range of motion. And then going along with that would be the dynamic balance that goes along with it. So when we're talking about the evidence behind shockwave therapy, since I realize this is new to a lot of the people in the room, just know that there is countless studies on this. I only referenced a few, and only for a few different conditions. But just for full disclosure, you know, whenever we're looking at any of these studies, there's always going to be limitations, right? These aren't being paid for by multi-billion-dollar drug companies. So some of the limitations that you will see in the research are going to be limited sample size. There's also a difference in the protocols, which is always an issue with regenerative medicine. You know, the way that, say, I practice prolotherapy or PRP is going to be completely different than the way that you know, say some other clinic down the street that just popped up out of nowhere does it, as well as it may be different than, you know, I'm sure a lot of us in the room practice. So, you know, there are varying treatment protocols. Some of the treatment protocols you see in the research are only calling for 2,000 shock waves, or basically 2,000 pulses. Whereas, you know, most standard protocols that are being recommended by some of the big organizations are saying, you know, 3,000 to 5,000. So that's a limiting factor in the research. Also, I think one of the biggest areas, at least for me, that I would like to see change is that there is not a whole lot of research, and actually there's little to no research looking at shockwave therapy, comparing it to the things that we're already using, the prolotherapy and the PRP. And then also looking at using it synergistically. So not comparing one to the other, but doing shockwave therapy and then PRP and prolotherapy. You know, there's little to no research on that. So there are some studies in the work without any published findings yet, but it's just something to be aware of. So when we start to get into that realm, we're kind of working on anecdotal evidence. And that's probably one of the tough parts, is when patients come into the office and they're saying, hey, you know, which treatment should I get? Should I do the shockwave therapy for this lateral epicondylitis, or should I do PRP? Which one is better? You know, I don't really have anything to reference to tell them, to say that, yeah, you know, evidence is showing that this one is better than the other. I can tell them anecdotally, at least from my experience, that, you know, I have more experience in using PRP and prolotherapy than shockwave therapy. But usually I answer that question by saying, you know, using both of them would probably be the best bet. And this is where we get into probably what I think is the most interesting part of shockwave therapy, or the most useful part, and that's going to be synergistic use. So using shockwave therapy just prior to doing your injections. So it can be combined with prolotherapy, PRP, ozone therapy. Now, the reason why we're seeing this synergistic benefit, which hasn't just been seen in my office, it's being seen in a whole bunch of different practices that are doing this. We're not 100% sure, obviously, right? We don't have the research. We have all these different pathways laid out and all this different science behind shockwave that we know about. But as far as why it works better with prolotherapy and PRP, you know, we can't say for certain. Some of the competing ideas are that it is actually, you know, obviously helping to break up calcifications and scar tissue, as well as increasing cell membrane permeability and already activating some of these pathways that we're hoping to activate with our PRP or prolotherapy already. Anybody else have any thoughts out there that's using shockwave? I see Dr. Lana's making a look, so. Yeah. Yeah. So, and that's what I tell my patients is, you know, we're priming the site. We're putting down our fertilizer before we plant our crops. So that's not very scientific, but it sounds good, for lack of, anyways. So what are the basics of the procedure? How does this actually look in the office? So you kind of know what the Shockwave device looks like. And obviously we have a vendor here that has a radial Shockwave device. So you kind of get the idea of what it looks like. We have our transducer, our probe there, kind of looks like an ultrasound probe in a way. And that is being placed on the patient's skin, that tip is, with an ultrasound gel. So then that way we have a nice medium to cross through. Obviously, we know that sound travels different speeds when we go through different mediums, right? Whether it's air, water, solid. So, we want to make sure that we have good contact with that ultrasound gel with a good amount of pressure. So that way that wave is propagating fully through the tissues and hitting our target without changing along the way. Now the parameters that we can change in therapy or in treatment, in our device, it's located on the handpiece there. And the things that we can change is the amount of energy being delivered. So when we're talking about radial shock wave, we are measuring things in terms of bar. Other times in the research, it may be millijoules or whatever, but on our device, it's being measured in bars of energy, going all the way down to 0.3 bars up to 4 bars or 5 bars. And obviously, as we go higher in the number of bars, then we can, penetrate deeper into the tissues. Then we also have the frequency of the shocks that are being delivered. So this is measured in hertz. So, any of us that remember doing any sort of electrical training, hertz is the number of revolutions per second. So typically we're doing 15 hertz for most protocols. So when I say that we're given 3,000, 5,000 shockwaves, that may sound like a lot, but you have to think, every single second there's 15 of them being delivered. And then of course the total amount of pulses or shockwaves that are actually being delivered with the treatment. And this can change based on the protocol, based on the patient, based on the area. But most protocols are calling for anywhere between 3,000 to 5,000 shockwaves. And just like the gentleman, I'm sorry, your name again? Yeah. Just as Doc over here mentioned, how many treatments, how far apart are we doing them? I usually want my patients to dedicate to a bare minimum of 3 treatments. Doesn't mean they're going to be fixed in 3 treatments, but bare minimum, I want them to at least commit to 3 treatments spaced optimally 1 week apart. We can space it out to 2 weeks, at least I have in our practice without any problems. But if we do 1 week apart, I think that's typically best. As far as when we can expect to see improvement, we saw some of those studies on osteoarthritis saying that at 4 weeks, patients were already starting to notice improvement. I think that's a little early, just in my opinion. Usually I'm thinking of Shockwave as following the healing cascade with any of our other techniques, right? That healing cascade is peaking around week 4 to 6, 6 to 8 with maximum collagen deposition. And then we have our maturation process where those fibers kind of grow and graduate and get their full tensile linear strength, which can take months and months. But I usually tell my patients, I don't want you to expect any improvement for at least 6 weeks. And maybe that's a little long. And obviously we see patients, and the ones that come to mind are, we treat a lot of high school and college wrestlers, and anybody that's treated those guys, oh my God, do they heal quick. It's just like phenomenal. You ever done prolotherapy on some of these high school wrestlers? It's just, they're almost like superhuman, So, some of these guys, they're feeling better in a couple of weeks, but obviously I never tell my patients that, because I never want to set that in their head that, you're going to heal in 3 weeks. So that's generally what I tell patients. Give it at least 6 weeks before you might even expect some improvement, although it can happen quicker. And then, as with any of the procedures that we're doing, we always need to be talking about risks, benefits, and alternatives, which is the very cornerstone of informed consent. And when we're talking about shockwave therapy, this is a non-invasive treatment, right? We're not breaking the skin with a needle or a scalpel. So that minimizes the risk of infection. Obviously, we don't want to be doing this treatment over any sort of active cellulitis, or if you're using this for example, erectile dysfunction, which is actually kind of how we got into using this treatment, given its ability to affect the vasculature. It's probably like the gold standard, one of the only things that can actually address the underlying cause of erectile dysfunction. And in those patients, if they have any lesions, things like that, obviously you don't want to be using shockwave over any lesions or STIs. So I think that's kind of commonplace, but otherwise, if it's clean, dry skin, your risk of infection is pretty much zero. There is some pain and discomfort, specifically when using radial shockwave devices. It's not excruciating pain. It's not the pain of PRP. Generally, how we mediate this is that we are starting at a low power. So for me, I'm starting, at 1 bar, sometimes even a little less if patients are a little tender. And I'm slowly increasing the power that we're using. Now, by the time we get to about 1,000 shocks, there's actually an analgesic effect involved with shockwave therapy. It actually seems to desensitize those nerve fibers. So sometimes patients will feel better prior to leaving the office. And I just make sure to let them know that that isn't the primary function of shockwave therapy. It's just a nice added benefit. But once we get that desensitization of the nerve fibers, then we can move up in power. So it's not as uncomfortable for the patients. So as with anything, always paying attention to your patients and listening to your patients is going to be key. And then there's always the risk of hematoma. Obviously, we're placing some pressure on the patient. Hasn't really been a problem. Sometimes I may end up with a little bruise. And then the last thing I would talk about when it comes to risk is that it depends on what shockwave device you're using. So radial shockwave devices, just so you know, are a class 1 medical device when it comes to FDA risk. So pretty much anybody could use it. In our office, only the physicians are using it. But otherwise, if we're looking at these focused shockwave devices, which we don't use in our practice, that's a class 3 medical device. So really it has to be a physician or a mid-level who's had a decent amount of training in it who can use that device. So at this point, I just thought I would share just some case studies from our office, a little bit of anecdotal evidence, give you some of my experience. I did talk to all my patients before I made this presentation, and they said, yeah, you can talk about my case, because they were all pretty happy with their outcomes. But still, I changed some demographics. I changed a few things just to kind of save their privacy. But nevertheless, the essence or the fundamentals of these cases are the same. So my first case is actually my first case with shockwave, using it for musculoskeletal. My original uses with shockwave were intended for men's health. So I did know that there were musculoskeletal uses for shockwave therapy, but I hadn't really explored that yet. But I had a gentleman in his 50s come in. He had this hip pain, had been going on for 3 months, had been getting worse. Of course, he went to go see his primary. They said, yeah, it's trochanteric bursitis. So they go and they give him a steroid shot, doesn't get any better. And this pain is still going on. Important thing to note about this patient and why shockwave came about was the fact that this guy was like deathly afraid of needles. So I have no clue why he even showed up to our office. I mean, he knew about our practice. He knew that, we're shooting patients all day, every day. So I'm not sure why he thought we'd be able to do anything without a needle, but fortunately that day we were. On physical exam, it was fairly unremarkable as far as any sort of joint dysfunction. When patients say hip pain, you want to know, is it actually in the hip or is it some sort of associated structure? And with him, Faber, Fadir were negative. He had pretty decent range of motion. But most notable was that, his pain wasn't on that trochanteric bursa. It wasn't lateral. It was posterior to that. So a lot of times trochanteric bursitis by primaries is, being misinterpreted. A lot of times it's actually, gluteal tendonitis. And that seems to be what it was with this gentleman. So he agreed to doing shockwave therapy since he didn't want any needles. And we ended up we did 4 treatments, and we spaced them 1 week apart since he was a local guy. It wasn't that hard for him to get into the office. We started at 1 bar just to keep him comfortable. We slowly moved up to 2.5 bars for a total of 5,000 pulses. And by the time I saw him back in 5 to 6 weeks, he had complete resolution of this pain that he had going on for 3 or so months. And I haven't seen him since, which is always a good thing. So this was my first experience with shockwave for musculoskeletal purposes, and was one of the ones that really turned me on to looking at the other uses for it, as well as some of the science behind it. My second case is talking about synergistic use. So I had a 48-year-old female who was a horse enthusiast. For any of us out there that are treating patients that are into horses, you'll know that it's not so much a hobby as it is, a way of life. Some of these people love their horses more than they do their spouse. So not being able to ride their horse is a huge deal for these people, right? It's their passion, it's their livelihood. And that was definitely the case with this woman. So she had this hip pain. She had already had MRI showing probably about, mild to moderate osteoarthritis with an anterior labral tear. We started off with PRP, and, she did really well with the PRP. She, probably about 75% improvement just using PRP and then following up with some prolotherapy after that to kind of keep that healing cascade going. But as many of us know, when we are establishing goals for our patients, they're not coming in because they have an anterior labral tear. They're coming in because they can't ride their horse. So even though a 75% improvement with regenerative medicine techniques is absolutely remarkable when compared to the other treatment modalities that they have available to them with their primary care or their orthopod, that last 25%, it can be a big deal. Almost make that other 75% meaningless. They might have a little bit less pain, a little better range of motion, but if they can't do what they love, then it doesn't really matter. So I know, and I'm not sure if anybody has talked about this yet. I know last year we talked a little more about this, but sometimes with some of these treatments, we hit that plateau. And for me, at least, it seems to be about 70 to 80% if a patient is a good responder. And it's that last 20 to 25% where, how do we address that plateau? Obviously, we're always reevaluating our initial diagnosis, looking at other reasons why the patient might not be healing properly as far as hormones and nutrition, things of that nature. And then also thinking, is there anything else that we can add in to help these patients get over that hump and increase their trajectory of healing? So interestingly enough, this woman is actually the one that brought up shockwave therapy to me. I wasn't the one that mentioned it to her. And again, this was early on in my use of shockwave. So it turns out that actually her horses were getting shockwave therapy. And there's a big crossover, it seems, between veterinary medicine and regenerative medicine, if any of you have seen that. And her horses were getting shockwave therapy with great effect. It turns out her vet was actually charging more than I was. So should probably change our prices, but. So we hit this plateau. We agreed to do the shockwave therapy, and how we did this was we did 3,000 pulses, going up to 2.7 bars of energy. And we just went anteriorly, just like we would go for an anterior intra-articular hip injection, especially since her labral tear was anteriorly. That was where most of her pain was. So we primed the site with the shockwave, and then immediately after, then we went and we did our basic prolotherapy. So just middle of the road, classic, 16.67% dextrose prolotherapy. And we did this for 3 rounds spaced 2 weeks apart. So this is one of those situations where, I wasn't doing it every week. I was doing it synergistically. So I made sure it matched up with whatever the other technique was that I was using. And one of the interesting things that we noted is that her inflammatory response changed. So before this, the prolotherapy, she's a little sore for maybe 2 days. And when we did the shockwave just prior to then doing the prolotherapy, she noticed that she was a little more sore, and that soreness would last for maybe 3 to 4 days. Now, admittedly, I probably could have just changed the concentration of my my dextrose prolotherapy, maybe bumped it up to 20%, but still was an interesting finding nevertheless. And sure enough, after 3 rounds of this, we got her over that hump. We got her that last 25% of improvement that she needed, and she got back to riding horses again, which was, she was ecstatic. Hadn't been able to ride a horse in years, so was a unbelievably rewarding case, and one of the ones that really, really got my interest piqued when it came to synergistic use. Now, this case, I will add a huge disclaimer on. I had a 74-year-old African-American female with sickle cell disease coming into my office with hip pain. This was not sickle cell trait. This was full-blown sickle cell disease. And Obviously, sickle cell disease, one of the bad complications of that is that as those red blood cells sickle in the periphery, they can destroy blood vessels. So these people are very prone to avascular necrosis. We're dealing with structures that don't heal that well because of their vascularity, and then we're killing off the blood supply to those areas, and then you're having death of that joint. So, current treatment approaches for this are pretty much nothing, right? You go to the orthopod, they go and they put you on some NSAIDs. I don't know, maybe they offer core decompression or something like that. And otherwise, it's just wait till you need the joint replaced. Nothing else you can really do for this. So she had already had 3 joint replacements due to avascular necrosis, and she did not want another joint replacement. I explained to her that, I looked for case studies, research, everything I could in terms of using regenerative medicine for avascular necrosis, and I didn't find a whole lot. I did find some. I think probably some of the best studies were more orthopedic as far as using core decompression and then combining that with PRP. So I made sure we went over all the risks, benefits, alternatives, and she completely understood that there were no promises. And I hate to say it, but not a whole lot of confidence on my part. But, I know that the mechanism of action of PRP and regenerative medicine techniques are there for this condition. It's just not having the experience as well as not having the studies to back it up. It kind of, you got to be honest with your patients sometimes, but I was willing to try it. And I thought that the science was there to back it up. So we ended up actually originally doing PRP for that hip. So she was originally coming in with a walker, severe pain. X-rays, of course, we got right away to figure out what was going on. Of course, they showed the same process that robbed her of her other joints, which was early avascular necrosis. So we did PRP initially, and she actually got remarkably better. I was absolutely floored, like 95% improvement with maybe 2 rounds of PRP. She was walking again without using a walker, and was just absolutely phenomenal. Very, very surprised. So when she comes back a couple months later and she's having knee pain, we automatically have to think, is this the same sort of process going on? So you get a repeat radiograph. Sure enough, it shows again, some arthritis, and then of course that early avascular necrosis. So we ended up doing PRP for this again, given just the remarkable benefit that she had with the PRP on the hip. But for some reason, she wasn't responding the same way as she did with her hip. And as some of us have said in this conference already, hips seem to be harder to treat than knees. So it didn't really make sense to me. We did a couple rounds of PRP. She wasn't getting the benefit, but still she didn't want a joint replacement. She still wanted our help. So I said, well, let's try to add in something else. And that treatment was shockwave therapy. So similar to our other synergistic uses of shockwave with PRP or prolotherapy, we ended up doing the shockwave to the knee just prior to doing our injections. And she did get improvement. She is up to about 50% improved, which is still pretty great. It's not perfect, but this is one of those cases that's ongoing. So I might be able to update you on it next year when I see you, because she's still undergoing treatment. And then my last case is of a 30-year-old gentleman who had a past medical history of psoriasis. And he was coming in because he had this left second digit that was getting painful, swollen, stiff. Wasn't really sure if he had an inciting incident or not. So unfortunately, when he first showed up, he didn't have the presentation. He didn't have that swollen finger. But automatically in our minds, we have to think, is this some sort of autoimmune thing? Are we talking about dactylitis or psoriatic arthritis? So, when talking with the patient, we had that discussion of, if this is an autoimmune inflammatory condition, doing our treatments like PRP, at least, normal PRP and prolotherapy, these could actually, peak that inflammatory cascade that's already causing this issue. So after shared decision-making with the patient, we decided to go with a different route. Obviously, we can use ozone in autoimmune conditions, and that's what we did for him. We started off with prolozone therapy for that finger, aiming at the A1 pulley as well as going down through those tendon sheaths in the joint. He didn't have quite trigger finger. He wasn't having triggering, but he definitely had the limited range of motion at that MCP, as well as tenderness to palpation at that A1 pulley. So that was the area of focus. So patient underwent 2 rounds of the prolozone, and the biggest thing that he noticed is that he was actually having this extended pain and swelling in his finger after the injections. And I know there are some good treatment approaches when patients are having extended pain from ozone therapy, but you know, I had good effect using prolozone with Shockwave for trigger finger. So I said, you know, why don't we add in Shockwave with this treatment? Because he didn't seem too concerned with the extended pain and swelling. You know, he went back to baseline afterwards. So that wasn't my, you know, initial reason for using the Shockwave, that extended pain and swelling that he was having. It was just trying to get some more benefit out of our treatment. And again, just another case study under my belt, just to kind of prove that what we were doing synergistically was working, and even in potentially autoimmune related conditions. So similar to the other cases, we did Shockwave therapy just prior to then doing our injections or to doing our prolozone. And the interesting thing that we saw is that extended pain and swelling that he was having in his finger, it disappeared when we added Shockwave just prior to it, which was kind of opposite of what happened with the other lady. My only reasoning behind this is that, you know, there is, you know, anti-inflammatory properties to Shockwave therapy, which is one of the reasons why we can use it in autoimmune conditions. So I was kind of curious why this was happening, and the patient, he was fairly open-minded. He said, you know, why don't we just hold the Shockwave therapy for the 5th treatment? I said, that's fine with me. So we just do our straight prolozone again. And sure enough, that extended pain and swelling returned after that treatment. So we followed up for a 6th treatment doing our Shockwave with the prolozone. And he ended up reaching goal, 100% improved, back to playing hockey and golfing, and happy with the results. So this wasn't meant to be an all-inclusive lecture on Shockwave therapy. It was just kind of meant to be an overview and give you some of my experience with it, as well as some of the science behind it. If I were to make some general conclusions for you guys here, it would be that, you know, Shockwave has been proven to be safe and effective for a number of different musculoskeletal conditions. You know, it can be used as a standalone treatment. I find it, at least in our practice, most useful and most impressive using it synergistically, and especially getting those patients that are hitting that plateau. It's just another tool in our toolbox that we can use to deal with that plateau, which can be a big struggle in our practices sometimes. Also, being able to use it in autoimmune conditions is a nice perk. Unfortunately, there's a paucity of evidence talking about the synergistic use or even comparing it to the treatments that we're already using. At least in my experience from what I've been able to find. And, you know, as with many things for a long time in the research, you're probably going to see that disclaimer, more research is needed. But there's tons of research out there, so have at it. References, if anybody would like to look through these, I'm sure the slides will become available. Unfortunately, I have the computer skills of an 80-year-old Amish lady, so I didn't know how to hyperlink any of the numbers with the other slides, but you can find them. Just copy and paste, I think. Okay, any questions, comments? Oh, actually.
I was just going to ask you, how do you get trained on doing this, David?
Yeah, so through Stores Medical. Actually, originally, again, we were using this for Men's Health. We signed up with a marketing group who I think legally I'm not allowed to refer to after we're no longer with them. But anyways, they're located out in Florida, and we actually went out there to get some training on it, as well as also when you buy the device that we bought, there's just a whole bunch of lectures and training videos, and the reps, I mean, the reps were awesome. You know, if we had a question about something or we weren't sure about a certain protocol or treatment approach, you know, they would find us something. But you know, they have some really good videos going over how to do this. So yeah.
You're actually doing the treatment and how long for time? How many minutes?
So unfortunately, I'm a doctor, not a mathematician, but you figure 15 hertz. We're going 3,000 to 5,000 pulses. Anybody do the math on that?
About 4.5 minutes.
Yeah.
There we go. There's Chuck. Yeah. Thank you, Chuck.
I have a question.
It
for
doesn't
you.
take that long at all. So when we're using it synergistically with PRP and prolotherapy, that's one of the really cool things about it, is that it's not like we're doing this whole other separate procedure. It's, you know, taking us 5 minutes. We're wiping off the ultrasound gel, and then we're good to go with our injections.
So have you used your protocol in the opposite fashion? So we have this Shockwave device in our clinic.
Awesome.
I've been trying to do both the injections and Shockwave together. I've been doing it in the opposite fashion.
Oh,
Because usually, so what we're doing now, what I've seen work really well with patients thus far is we'll do the injections, we'll wait, and then we'll add the Shockwave treatment at the end.
Yeah.
So synergistically, it's been working great,
Yeah.
but I've been doing it in the opposite fashion
Yeah.
as you described. But
Yeah.
we'll actually 3,000 pulses. It's barely a few minutes. We actually do 6,000.
Mhm.
So we're pretty high up there.
Yeah.
So they'll do like each round is about 2,000 pulses. Have you seen?
yeah. So my
difference?
reasoning for not doing it prior to that is that there does seem to be some evidence or some indication that, you know, when you have lidocaine in the area during the treatment, or even on the area during the treatment, it actually affects the results. The other reason is being that I want to find that maximal point of TTP, tenderness to palpation. So if I have the patient numbed up, I mean, I don't know if I'm hitting the right spot. I mean, by anatomical landmarks, I can assume I'm hitting the right spot. Another thing I didn't really reference or talk about in this lecture is, you know, we have these treatment protocols, 3,000 to 5,000 pulses, but usually after that, what you'll see are these resulting secondary pain points develop. And then we treat those out too with a couple thousand pulses, usually using a different head. And then the last reason why I'm not using it after the fact is because I have no idea what a shock wave, which is a fairly significant force if you think about it, I have no idea what that's doing to platelets or to alpha granules, like if I'm using PRP. So the last thing in the world I want to do is potentially, you know, totally destroy whatever it is that, you know, I was trying to inject into the patient. I'm not saying that the way that you're doing it is wrong. It's just
Yeah.
that was my thinking. And I think, you know, it kind of goes along with what I said. You know, we need some more good research on this synergistic use. And I mean, what if it's a way of fracturing platelets and releasing those alpha granules? I mean, that would be amazing. But what if it's doing the opposite effect too? We don't know, or at least I don't know.
Thank you.
If people are interested in possible training, come to Naples next year. Art and I are in the process of discussing either having a breakout session or a short lead-in. So make sure you come to Naples.
I just like to say that wasn't a question, that was a statement. Please sit back down.
I was just wondering about any kind of negative effects. You mentioned, basically hematoma and that type of thing,
Yeah.
but are you doing x-rays on any of these areas prior to shockwaves? I'm just thinking, what if someone has a small fracture or there's something where the contraindication to using this high intensity pulsing device?
Yeah, no, 100%. So I realize I probably didn't really go over that in full depth, but obviously, you know, always having a full history and physical is important. You know, if there's any idea that, you know, there is a fracture there, then of course I'm going to get an X-ray. But routinely, am I getting X-rays prior to doing this treatment? No, you know, not if it seems like a straight cut musculoskeletal issue. Also, I think if you were to do this over a fracture, you would probably know pretty darn quick. So although there are treatment protocols saying, you know, you start at 1 bar of power, which is fairly low, and moving up to, let's say, 2.7 bars, which is higher power, it's always listening to your patient, and it's always, you know, and increased up to 2.7 bars as patient tolerated. So with a fracture, patient isn't going to be able to tolerate that at all. I would abort treatment completely. Yeah. All right, and then I'll be doing a workshop this afternoon. I know in your little manuals there, it says I'll be there in the morning. I'll actually be at anatomy lab, but I think Chuck, the rep for stores, he'll be there this morning, at least show you the device and whatnot. And then I'll be there in the afternoon if anybody wants any areas treated. So.